Hello, this is Dr. Bhaumik, and today I'm going to present another case of non-autoimmune thyroiditis, but this is not acute suppurative thyroiditis, which I just presented before this submission. This patient was admitted by my colleague Dr. Bilbao. She is in Farmington, Connecticut now, and we manage this patient together. Infectious disease also involved in the management, and this patient admitted to our hospital, so this is our patient. And the prior to this, the one that I presented was also admitted in our hospital. This is our brand new endocrine clinic and other subspecialty clinic. This case is the second case, as I have said, and the goal is objective and goal is to discuss the presenting symptom, sign symptom pathogenesis, differential diagnosis of this condition. We will also discuss the imaging studies that will help you to make the diagnosis, and we'll discuss the management as well as literature review about this condition. This patient was a bit younger, is 7 years old, presented with 1 week history of neck pain, sore throat, and running fever up to 101 degree Fahrenheit. She does have difficulty in swallowing, hoarseness of the voice, and some weight loss with poor appetite. She does have URI symptom, and in our clinic we did a rapid strep throat test, rapid strep test, which was negative, and the flu test was also negative. Patient was admitted to the hospital for further management, and physical examination did show the tenderness over the thyroid gland with generalized enlargement of thyroid, and there was no bruit. There was some limited neck movement and any effort to move the neck elicit pain. No cervical lymphadenopathy was appreciated. Temperature was 101 degree Fahrenheit, heart rate 118. She looked non-toxic but dehydrated. Rest of the physical examination was unremarkable. The laboratory test on admission that we did shows just slightly elevated WBC count and neutrophil. Monocyte was 7%, lymphocyte about 10%. SED rate was clearly elevated to 97, and CRP is also elevated to 23 milligram per liter. And what was the also remarkable thing in the lab was she was clearly hyperthyroid. Her thyroid function test shows a free T4 of 4.09 Ng per dl, and the references has been in the parenthesis. T3 was 334. TSH was suppressed significantly 0.01. Thyroid antibody and antithyroglobulin antibody, including TSI, thyroid stimulating immunoglobulin, to rule out both Hashimoto's thyroiditis and Graves' disease was negative. The other workup did include a mono test, TB skin test, blood cultures, and those are negative. She had normal chemistry profile, so was the electrolyte. The radiological examination, uh, we did the CT scan, which was suggestive of thyroiditis, but also revealed an area of possibly interthyroid abscess on the left side. However, when he did the thyroid sonogram, which did show the definitive enlargement of both right and left lobe of thyroid, the measurement is given, and clearly they are definitely more than the normal of that age, and isthmus is also enlarged to 0.68 cm. There was no definitive fluid or suggestion of abscess, and sonographic finding was more consistent with subacute thyroiditis. So here in the CT scan and sonographic finding did not agree with each other. Since the questionable lesion or abscess was on the left side by CT, we did go ahead and did a barium swallow to rule out any piriform sinus fistula, which was unrevealing. Now here we say that this is the area of suspicion, but in generalized enlargement of thyroid gland with diffuse hypoechoic shadow was all over on both thyroid gland, as we have illustrated in these paragraphs. The hospital patient started on IV clindamycin since the CT did suggest questionable thyroid abscess. So he started on antibiotics and anti-inflammatory medication, non-steroidal, and fever continued. And after 3 days, the fever did not remit. So at this point, we discontinued the clindamycin and started on methylprednisolone, IV 30 milligram daily, and remarkable response was seen within 24 hours. And then after 4 days, we switched to oral prednisolone, and total duration of therapy was about 10 weeks. However, we did taper the dose accordingly. During this period of time, thyroid function was monitored, and there was progressive decline of free T4, and thyroid antibody was also negative, repeat 1, and the SED rate as CRP was coming down. Now, let's see if we go back and discuss the literature about this condition, and this is known as subacute thyroiditis, SAT, and it's commonly referred also as de Quirinius thyroiditis by the name of the famous thyroid surgeon de Quirinius. I may not have been pronouncing the name right, so my apology if this is wrong. And it is characterized by spontaneous remitting inflammatory condition of thyroid gland. However, it is extremely rare in children. It lasts for weeks to several months, and the recurrence is very possible. Whole thyroid gland is involved, and it is enlarged by 2 to 3 times. It is tender on palpation, and usually there is no bruit over the thyroid gland. Occasionally one can see some cervical lymphadenopathy, but not significant enough. Usually the condition may be preceded by low-grade fever, flu-like symptoms, and this condition may persist for weeks before you can see any changes of the thyroid status, both in terms of measurement and function. Many of them may have sore throat. So, etiology and pathology of subacute thyroiditis is this. It is not an autoimmune process or disease, and it's most likely is an infectious etiology by viral infection, and the wide range of virus can involve as etiological factor that could be Coxsackie, adeno, mumps, measles, and so forth. About 72% of the time, the patient may have AACE positive haplotypes AACE BW35, and the familiar occurrence has also been noted that in the same family, if they share the same kind of AACE haplotype. And macroscopically, it's a striking resemblance with cancer, but microscopically it looks like subacute chronic granulomatous inflammation. So this is also known as granulomatous thyroiditis, or it is also known as giant cell thyroiditis. And inflammatory changes could be at various destructive stages. Approximately 60% of the patient present with thyrotoxic symptoms, but more than that will probably present with thyroid hyperfunction but may not be that symptomatic. So it could be 60 to 80%, but about 60% of the time they are thyrotoxic. And about less than 10% of the cases in the adult literature has been reported to have hypothyroidism. It is important to make sure that one is not dealing with Hashimoto's thyroiditis, especially what we call Hashitoxicosis or toxic phase of Hashimoto's thyroiditis, and that can be ruled out by thyroid peroxidase antibody, anti-thyroglobulin antibody, and also one need to rule out hyperthyroid due to the Graves' disease, and so thyroid stimulating immunoglobulin or thyroid stimulating antibody has to be checked. Mildly elevated CRP and ESR with mild lymphocytosis or monocytosis may be noted. And if one proceeds with radioactive iodine uptake, which will be low during the acute phase, as is exactly same thing happened in Hashimoto's toxic phase, and sonogram showed enlarged thyroid, but there is no abscess, and it is a diffuse enlargement of thyroid gland. Both lobes are equally infected, so there is no particular area that will be affected more than other. As far as the treatment is concerned, the condition mostly is self-limiting condition, but most of the time anti-inflammatory medication as well as pain control is all that necessary. But however, if the patient do have significant tachycardia or sign symptom of thyroid toxicity, then a beta blocker is a very good idea to block those symptoms. Steroid is useful in little bit aggressive little bit aggressive form and severe cases who continue to show the deterioration and the patient symptomatology continue to not to remit over the period of 3 to 4 days, as in our case. As far as the use of steroid concerned, many of them, if they have no problem with the vomiting, can be managed by the oral steroid like prednisone. The duration does not have to be 10 weeks or maybe even more or less. It will be depending upon the improvement of signs symptoms. And since our patient was in the hospital, we started on IV methylprednisolone. We gave for 4 days, but probably 48 hours would have been enough, followed by oral. But that's a judgment call, and I'm not going to spend too much time on that. This is the diagram we made, and this actually shows the recovery thyroid test, and this is to T4 and this yellow is TSH. So let's pay attention to these two. So in the beginning, obviously T4 level is high and TSH is suppressed, and T4 levels continue to go low to a point where they may be in mild degree of hypothyroid range, and slowly and gradually come back to normal range. However, as far as the TSH is concerned, initially suppressed, and it is not surprising that TSH goes up, and the main function of that is to bring the T4 within the normal range. Then you become euthyroid. One point I like to make here is that one can see this kind of in Hashimotosis or toxic phase of Hashimoto's thyroiditis. Very similar picture. Only difference is that right here in SAT they will remain normal thyroid function, but Hashimotosis many a times after that they go to hypothyroid state, and then TSH continue to go up. So this is a point that we are going to emphasize a little bit in our next slide. We made this slide to see that whether we can make a significant, meaningful differentiation of three conditions which may mimic or initially may be confused with various conditions that has been depicted here. So let's see at that. When we put it in the history is the fever, then physical examination, but I'm not going to go through the whole thing, but points that I'm going to make that will be very helpful for endocrinologist or endocrine fellow to develop the mastery of the situation. And in case we put acute suppurative thyroiditis, which is a bacterial disease, subacute thyroiditis, which is a viral disease, and Hashimotosis or toxic phase of Hashimoto thyroiditis is an autoimmune process. So we put this one, but as you can see that in acute suppurative thyroiditis, the swelling is about 10% of the time it is localized and mostly on the left side. And in SAT it is generalized enlargement of thyroid gland, and here is also generalized enlargement of thyroid gland. So again, the difference is right here, as you can see, thyroid function is normal in acute suppurative thyroiditis, and as I said, in SAT more than 50% is initially will be hyperthyroid and then become normal in weeks or a month, and TSH, the graph we saw you the previous slide, we'll explain that how TSH goes up slowly to bring the thyroid function within normal limit. And here, the hyperthyroid and the low TSH is almost 100%, and then it may followed by hypothyroidism, as typically seen in Hashimoto's. And the other thing is that if you do the antibody study, this will be positive. And if you do the uptake, it will be low patchy uptake, which could be confused with uh, SAT. And so I think that this will be a very good table or the chart that you can follow to differentiate between these three conditions. Clinically may behave similar, and so this will be a very helpful thing for the purpose of the exam and easy to read through. Now I put another condition which is frequently comes as you go through and start reading about thyroiditis in a standard text or even the literature review. It will show it's called Riddle's thyroiditis, and again this is even more rare in pediatrics, and many people call it as a iron hard woody thyroid mass and associated with compressive symptoms, either maybe a problem with a little bit breathing, problem with tracheal compression, or esophageal compression, maybe difficulty in swallowing. And this is believed by most of the endocrinologists is a Hashimoto's thyroiditis, but a very aggressive form, and it is called fibrotic thyroiditis. And this fibrotic thyroiditis is also seen in the younger children, less than 10 years of age, who present with hypothyroidism, and physical examination failed to reveal any thyromegaly because the fibrotic process has replaced the thyroid gland. Actually, I did in this series of lecture and discussion, I did present a case, and there I have made more point. And in order to make the diagnosis, one need to have the histopathological confirmation, and the inflammatory infiltrates should not have any giant cell. If you have a giant cell, that kind of goes to the diagnosis of decurvance, and no lymphoid follicle, as one could see in Hashimoto's, and no suggestion of any malignant process or granuloma. So those had to be excluded by histopathological examination. Thyroid antibodies is present more than 60% of the cases. So if that is there, it does not fall within the criteria of non-autoimmune thyroiditis anymore. But one of the important things to note here also, in renal disease, sometimes parathyroid may be involved. None of the thyroid condition per se will have involvement of parathyroid, but this one will. As a result, there may be a fibrosis of parathyroid gland, and the patient do develop hypoparathyroidism. And iodine scan and uptake will be low, and the imaging study will show moth-bitten appearance or patchy images of thyroid gland, as one can see in Hashimoto's thyroiditis. Treatment-wise is non-specific therapy, symptomatic, but if the obstructive symptoms, either respiratory or digestive or esophageal compression, is significant, one had to do the removal of isthmus, called isthmusectomy, or removal of isthmus, to relieve the pressure on midline structure like trachea and esophagus. And this patient will be hypothyroid and so will need levothyroxine replacement. So if they have a associated hypoparathyroidism, so they will need vitamin D as well as calcium supplement. Corticosteroid has been found to be effective in many cases, especially if there is significant pressure symptom. So this renal thyroiditis is actually not a non-autoimmune thyroiditis, as I have in the beginning said. We are going to talk about non-autoimmune. But however, this has been discussed, and prior to our better knowledge, it was considered as a subacute thyroiditis, and so it's no more. Let's go back to the follow-up of our patient. At 6-month follow-up, thyroid is back to normal, no enlargement, no tenderness. Thyroid function is now completely normal free T4 TSH, and we did repeat again the antibodies, both TPO-ATG and TSI was negative. The last follow-up was at around 16 months after diagnosis, where the patient continued to show normal normal thyroid function and negative thyroid antibodies. So, take-home message or key point of subacute thyroiditis is they manifested with the fever, neck pain, generalized enlargement of thyroid gland with tenderness. It's a viral etiology, presumed to be a viral etiology. A lot of time the causative virus may not be identified that easily. Patient usually present with hyperthyroid state, and then as the recovery process goes on, it goes through a transient hypothyroid state and then euthyroid state and stay there. And again I am repeating, that may not be happening if the patient has hashitoxicosis. They may remain euthyroid, but they may mostly will be hypothyroid. Treatment is again non-steroidal anti-inflammatory drugs. Steroid does help clearly, especially the cases are a little bit more severe, and the beta blocker to prevent some of the untoward symptoms that patient may experience because of high T4. So this is the pioneer physician of thyroid disease, and these are the people who work so hard, and we are just following there. Whatever they have discussed, maybe elaborating on that. And this is Dr. Fritz D. Kurivan, and you know the Hikaru Hashimoto's, and this is Robert Graves. Thank you. And my next presentation will be another interesting case, and all the presentation that will be submitted here is our patient, and we'll have a referral wherever it has been presented. And this discussion, especially these last two, will be also helpful for pediatric infection disease. I don't think they see that much of that, and pediatric endocrine fellows, pediatric endocrinologist and the pediatrician will be more appropriate, will get a more appropriate understanding of this condition. Thank you again.